I asked my friend and he said it was alright to mention him, so thank you for allowing me to share your journey. A man I met a couple months ago just completed an inpatient facility where he invested 30 days to realize his systemic issue wasn't the alcohol. It was the pain he used the alcohol to cover up. He learned more about the trauma he carried for 29 years. He has been to 3 therapists, talked about it in meetings, journaled about it, prayed about it. 29 years of carrying it. Then someone suggested EMDR. He did not know what it was. He thought it sounded strange. Moving your eyes back and forth while thinking about the worst thing that ever happened to you? That cannot be real. He tried one session. Then one more. He told me afterward, it is still there. The memory. But the weight is gone. Like someone reached inside his chest and unhooked something. Have you ever thought about therapy and immediately pictured lying on a couch, talking about your childhood for years, spending money you do not have, and not seeing results? Most people do. And for most people, that image is what keeps them from ever making the call. What if I told you that some of the most effective therapies for addiction do not look anything like that? That some take weeks, not years. That some do not even require you to talk about the trauma in detail. And that some use your own brain's hardware to do the repair. This episode is the most information-dense one we have done. I am going to move faster than usual. If something interests you, pause this and look it up. Everything I reference today, every therapy, every resource, every link, is in the episode description. There is a vast list of therapies out there, so for time's sake, the ones I mentioned today are more commonly used and not the only ones available. Discuss this with a clinician or therapist to see what could help you best. Thank you for taking the time to understand your options. This is not passive. This is agency. This is Recovery Decoded, Episode 6, The Therapy Guide. Your body is healing. Here is the map. You choose the route. Before I walk through these, I want to be clear about what I am doing and what I am not doing. I am not ranking these therapies. I am not telling you which one is best. What I am doing is organizing them by how much scientific research currently exists behind each one. That is not a measure of how well they work for any individual person. It is a measure of how many studies have been completed, how large those studies were, and how confident the scientific community is in the results right now. A therapy in the emerging category might end up being more effective than anything in the proven category. We just do not have enough data yet to say that with certainty. So when you hear me say proven, emerging, or experimental, think of it as where the research is today, not where the therapy ranks. And one more thing before we start. Some of the therapies in the experimental category are not new. Psilocybin has been used for centuries and was studied in clinical settings as far back as the 1950s. LSD was used therapeutically for decades before it was banned. Ibogaine has roots in West African spiritual traditions going back generations. These substances are not experimental because they are untested. They are experimental because the modern clinical research was interrupted by politics in the early 1970s and is only now resuming. The substances are old. The clinical protocols being built around them are new. Hold both of those truths at the same time. The first group, therapies with strong scientific evidence. These have decades of research, thousands of participants studied, and are widely available right now. If you are looking for a starting point, this is where most clinicians will begin. Number 1, cognitive behavioral therapy. CBT, the most studied therapy for addiction in the world, used in 94% of US treatment facilities. Here's what it does in your brain. Remember the cue routine reward loop from episode 4? CBT teaches you to interrupt it. It targets the connection between your thoughts, your feelings, and your behaviors. When a craving hits, your brain runs a thought. I need this. I cannot handle this. One more time will not hurt. CBT trains you to catch that thought, challenge it, and replace it with a different response. Over time, you are strengthening your prefrontal cortex's ability to override the automatic craving program. The evidence. A meta-analysis of 34 randomized controlled trials with over 2,300 patients found moderate effect sizes across substance types. Largest effects for cannabis, followed by cocaine, then opioids. Who this fits? People who want structured, goal-oriented work. People who want tools they can practice between sessions. People who want to understand the patterns driving their behavior and learn to change them. Number 2, Dialectical Behavior Therapy, DBT. Originally created for borderline personality disorder, DBT has become one of the most effective therapies for people dealing with addiction and emotional regulation problems at the same time. It builds 4 skill sets: mindfulness, being present without reacting, distress tolerance, surviving a crisis without making it worse, emotion regulation, understanding and managing intense feelings, interpersonal effectiveness, communicating your needs without destroying relationships. The evidence. Strong outcomes for people with co-occurring personality disorders and addiction. Significant reductions in drug use compared to standard treatment. DBT combines individual therapy with group skills training. Who this fits? People whose emotions are as much of a problem as a substance. People who have been told they are too sensitive, too reactive, too intense. People who need skills for the moment, not just insight about the past. Number 3, motivational interviewing. MI. This one is different. It is not a therapy you do to yourself. It is a conversation style your therapist uses with you. MI does not tell you what to do. It does not lecture. It does not push. It helps you find your own reasons to change. The therapist asks open-ended questions, reflects what you say back to you, and helps you see the gap between where you are and where you want to be. You arrive at the decision yourself. The evidence. Strong, especially effective for people who are ambivalent or resistant to being told what to do. Often combined with CBT as a 1-2 approach. MI gets you in the door, CBT gives you the tools once you are there. Who this fits. People who are not sure they are ready. People who have been pushed into treatment and resent it. People who need someone to listen, not lecture. Number 4. Contingency management. CM. This one has the strongest effect sizes of any behavioral therapy for stimulant use disorders. You get tangible rewards for staying sober. Vouchers, gift cards, privileges. Every clean drug test earns a reward. The value increases the longer your streak continues. Your brain learns a new association. Sobriety equals reward. It targets the same dopamine system we talked about in episode 1. The evidence. Multiple meta-analyses. The VA has implemented contingency management nationally for stimulant use disorders because the data is that strong. Who this fits. People dealing with stimulant addiction. People who respond to concrete incentives and measurable progress. Number 5. Eye movement desensitization and reprocessing, EMDR. This is the one from the opening story. While you recall a traumatic memory, a therapist guides you through bilateral stimulation, usually eye movements following a light or the therapist's hand. This activates both hemispheres of your brain simultaneously and appears to help your brain reprocess the memory so it loses its emotional charge. The memory stays. The weight lifts. This matters for addiction because trauma and substance use are deeply connected. Many people started using to manage pain they had no other tools for. EMDR addresses the root without requiring you to narrate the trauma in detail. You do not have to relive it out loud. The evidence. Over 30 controlled outcome studies. The World Health Organization and the VA both recognize it as a first-line treatment for PTSD. Research shows it significantly reduces both PTSD symptoms and cravings in people with co-occurring trauma and addiction. Who this fits. People whose addiction is rooted in trauma. People who have done years of talk therapy and the weight is still there. Number 6. Multi-channel eye movement integration, MEMI. This is a related approach I want you to know about. It was developed by Dr. Mike Denninger and shares DNA with EMDR, but works differently in some important ways. Where EMDR uses back and forth bilateral eye movements, like watching a tennis match. MEMI uses structured patterns across your entire visual field. Slower, sweeping movements that activate multiple brain networks simultaneously. And here's what makes it stand out for some people. It is content-free. You do not have to describe the trauma, not even in general terms, not even a little. Your brain does the processing without you narrating anything. MEMI targets 3 channels at once: what you see, what you feel emotionally, and what you feel physically in your body. Most trauma therapies address 1 or 2 of those. MEMI addresses all 3. The evidence is earlier stage than EMDR. Case studies and small clinical trials, rather than 30+ large controlled studies. But the outcomes are promising. Practitioners report clients resolving decades-old trauma in 1 to 2 sessions. And for people who find EMDR too activating, or who need a completely private approach, MEMI offers a gentler path to the same destination. If you are looking for a trauma therapist, ask if they are trained in MEMI as well as EMDR. Having both options gives you and your therapist more flexibility. Now, before we move to the next group, I want to cover the treatment structures. These are not therapies. They are containers, levels of care that determine how much support you receive and how intensively you receive it. Think of it as a ladder. You step up or step down based on where you are. Moving between levels is normal. It is not failure. Residential treatment. Inpatient. You live at the facility 24/7. Medical supervision around the clock. This is the most intensive level, typically recommended for severe addiction, medical complications during withdrawal, or when the home environment is unsafe for recovery. Most programs run 28 to 90 days. Insurance coverage varies, but many plans cover at least a portion. Partial Hospitalization Program, PHP, sometimes called day treatment. You are at the facility during the day, usually 5 to 7 days a week, 6 to 8 hours per day, but you go home at night. This is near hospital level care while preserving your independence. You might do group therapy, individual sessions, psychiatric appointments, and medication management all in one day. PHP is often the step down after residential, or the step up when outpatient is not enough. Intensive Outpatient Program, IOP. You attend multiple sessions per week, usually 3 to 5, for about 3 hours each. You live at home, you keep your job, you sleep in your own bed. IOP includes group therapy, individual sessions, and education. It is the bridge between structured treatment and full independence. Sober living. This is not treatment. It is structured housing. A drug-free environment with house rules, accountability, and peer community. You typically attend sober living while doing IOP or after completing residential treatment. It is the bridge between the treatment facility and living fully on your own. Most sober living homes require residents to attend meetings or therapy, maintain employment or be actively looking, submit to drug testing, and contribute to household responsibilities. Sober living is typically self-pay, but some state programs, insurance plans, and nonprofits offer financial assistance. Ask your treatment provider about options in your area. The simplest way to think about it, residential is the most support. PHP is full days with home at night. IOP is part-time with full independence. Sober living is the housing bridge. And all of them can include any of the therapies we just covered. The container holds the work. You choose which work goes inside it. The second group, therapies with promising scientific evidence. These have clinical trials, peer-reviewed data, and growing availability. The research is real. It is just not as deep as the first group yet. Some of these are entering mainstream practice right now. Others are close. Number 1 in this group, ketamine-assisted therapy. This is the only psychedelic adjacent substance currently in widespread legal clinical use for mental health. Ketamine blocks NMDA receptors, which promotes rapid neuroplasticity, your brain's ability to form new connections quickly. When combined with structured psychotherapy, it creates a window where your brain is more open to therapeutic change than it normally would be. The evidence. Extensively studied for depression. One phase 2 trial for alcohol use disorder showed 86% abstinence over 6 months. The FDA has approved a nasal spray version called Spravato for treatment-resistant depression, available now in clinics under medical supervision. The honest limitation. Effects can be temporary. It creates a window for change. Therapy helps you sustain it. Number 2. Psilocybin-assisted therapy. The active compound in psychedelic mushrooms. It activates serotonin 2A receptors and induces neuroplasticity and profound psychological shifts. Remember, psilocybin has been used for centuries and was studied clinically as far back as the 1950s. The modern research is a resumption, not a beginning. The evidence. Johns Hopkins research showed sustained depression remission in over 50% of patients at 6 months. Compass Pathways reported positive phase 3 results in 2025 for treatment-resistant depression. Trials for substance use disorders are ongoing. The honest limitation. Not yet FDA approved for any indication. Potentially available in broader clinical settings by late 2026 or 2027. If you are interested, search for active clinical trials at clinicaltrials.gov. What do you want to do with all this money? Number 3. Transcranial magnetic stimulation, TMS. No drugs involved. A device sends non-invasive magnetic pulses through your skull to stimulate specific brain regions, usually the prefrontal cortex. This modulates neural activity and reduces cravings. FDA approved for depression. Multiple randomized controlled trials show craving reduction for addiction. Treatment involves daily sessions over 4 to 6 weeks. Number 4. Neurofeedback. Real-time brainwave training. Electrodes measure your brain activity, and you learn to regulate your own neural patterns through a feedback loop, like physical therapy for your brain. Emerging evidence. Smaller studies show promise for reducing impulsivity and cravings. Consider it as a supplement to other therapies right now, not a replacement. The third group, therapies in early stage research. The data looks promising, but is limited. These carry real potential and real risk. I want to repeat, never pursue these outside of legitimate clinical or research settings. And remember what I said at the top. Some of these substances have been used for centuries. They are not experimental because they are untested by humans. They are experimental because the modern clinical protocols are still being built. Number 1, ibogaine, an alkaloid from the iboga tree used in West African spiritual ceremonies for generations. It affects multiple receptor systems and has shown rapid reduction in opioid withdrawal symptoms and persistent changes in cravings. The honest assessment. Open label studies in case series only. No completed phase 3 trials. Ibogaine carries significant cardiac risks, a condition called QT prolongation that can be life-threatening. It is not FDA approved. It is not legal in the United States. It is available in some international clinics. People have died from ibogaine administered without proper medical supervision and cardiac screening. The research is compelling enough that major institutions are pursuing it seriously, but the safety protocols are not yet where they need to be. Number 2, LSD-assisted therapy works similarly to psilocybin on serotonin receptors. Historical data from the 1950s through 70s involved over 40,000 individuals and showed promise for addiction. Modern phase 2 trials have resumed, currently legal only in clinical trial settings. Number 3, ayahuasca, a DMT containing brew used in indigenous ceremonial contexts for centuries. Observational studies show reductions in substance use. No large-scale randomized controlled trials. Quality and safety vary enormously. Potential for dangerous drug interactions, particularly with antidepressants. Ceremonial context is not clinical context. Approach with significant caution. All right, that is the landscape. Let me help you see how all of these fit together. Because knowing what each therapy is matters less than understanding when you would use one versus another and how they combine. CBT versus DBT. If your problem is, I keep making the same bad decisions. I keep falling into the same patterns. That is CBT. CBT changes thought patterns. If your problem is, I feel everything at 100% and I cannot regulate, that is DBT. DBT builds emotional skills. Many people benefit from both. They target different layers. Motivational interviewing is usually the on-ramp. A good therapist often uses MI in the first few sessions to build trust and find your motivation before shifting into CBT or DBT. If your therapist starts with open questions before giving you homework, that is MI at work. EMDR and NEMI versus talk therapy. Talk therapy, like CBT, works top down. Change your thoughts, your feelings follow. EMDR and MEMI work bottom up, process the stored trauma directly, and the thoughts change on their own. Neither is better. They target different layers. If you have done years of talking and the weight is still there, the trauma might need bottom-up processing. Contingency management is almost never standalone. It layers on top of another therapy. You do CBT and get rewards for clean tests. The combination is stronger than either alone. The treatment structures: residential, PHP, IOP, sober living, are not therapies. They are containers that hold the therapy. You can do EMDR in a PHP program. You can do CBT while living in sober housing. The container matches the support level you need. The therapy inside it is a separate choice. Now, if you are wondering where to start, here is the general pathway that responsible clinicians follow. Step 1. Assessment. Before any therapy, see a doctor or licensed clinician who specializes in addiction. They evaluate your specific situation, substance history, mental health, trauma, severity, medical status. This determines your starting point. Nobody should be walking into any therapy, especially emerging or experimental, without this step. Step 2. Proven therapies are usually first line, not because they are best for every person, but because they are the most studied, most available, and most covered by insurance. A responsible clinician will typically start with CBT, DBT, MI, or EMDR, depending on your presentation. Medication-assisted treatment may run alongside therapy to stabilize your brain chemistry so you can engage in the work. Step 3. If first-line treatments are not sufficient, your clinician may recommend exploring emerging options like ketamine-assisted therapy or TMS. A responsible ketamine clinic will ask what therapies you have tried and whether you have an ongoing therapist. If they do not ask, that is a red flag. Step 4. If you are considering anything in the experimental category, do so only through legitimate clinical trials or regulated settings with full medical screening. You do not skip to this step, not because experimental therapies are not real, but because the proven ones might be all you need. And if they are not, you want a clinical team guiding the decision, not a search engine. You can move between these steps. You can combine them. Recovery is not a straight line, and neither is treatment. But having a roadmap keeps you safe while you figure out what works for your specific brain, your specific history, and your specific life. Don't. How do you actually find a therapist? Because this is the part that stops most people. Where to look? Psychology Today has a therapist finder where you can filter by insurance, location, and specialty. SAMHSA has a treatment locator at findtreatment.gov. Your insurance company has a provider directory. Call the number on the back of your card and ask for in-network behavioral health providers who specialize in substance use disorders. If you are a veteran, the VA provides therapy at no cost. call 1-800-827-1000. All of these links are in the episode description. What to say on the first call? Here are the exact words. I am looking for a therapist who has experience with substance use disorders. I am currently in recovery, and I want someone who understands addiction. Do you have availability? And do you accept? Then name your insurance. You do not have to tell your story on the phone. You do not have to be ready. You just have to make the call. If they do not have availability, ask, do you know someone who does? One call often leads to 3 options. For insurance, if a therapist is out of network, ask about a sliding scale. If you have Medicaid or Medicare, call your plan and ask for the behavioral health provider list specifically. If you are uninsured, community mental health centers offer therapy on a sliding scale based on income. SAMHSA's helpline at 1-800-662-4357 can help you find free or low-cost options. Red flags. If a therapist dismisses your substance use without assessing it. If they are not familiar with any of the approaches I covered today. If they make you feel judged. You are allowed to try a therapist and switch. The first one does not have to be the right one. The goal is to start. Real talk. If you have been avoiding therapy because of what you think it looks like, I want to challenge that picture. EMDR can process a trauma you have carried for decades in a handful of sessions. MEMI can do it in 1 or 2 without you saying a word about what happened. CBT typically runs 12 to 20 sessions. Contingency management shows results from the first clean test. These are not open-ended commitments. They are targeted interventions. In asking for help, making that phone call, walking into that office, that is not weakness. You have survived things that most people cannot imagine. You got yourself here. Asking for a professional to help carry the weight is not giving up. It is leveling up. Someone told me recently, I thought asking for help meant I was not strong enough. Now I think asking for help is the strongest thing I have ever done. I think they were right. Here is what I want you to do this week. Look up one therapist. You do not have to call. Just find a name. See their profile. Let it feel less abstract and more possible. And if you are already in therapy, bring this episode up. Say, I heard about EMDR or MEMI or contingency management, and I am curious. A good therapist will not be threatened by that. They will be glad you are engaged. If there is something we have not covered that you need to hear about, a specific therapy, a question about medication, insurance nightmares, how to talk to your family about what you are going through, put it in the comments. This show is built around what you are actually going through, not what we think you should hear. You decide what comes next. And whatever you are facing this week, remember, nobody is making this choice for you. Not a therapist, not a program, not this podcast. You are choosing to understand. You are choosing to show up. That is yours. Nobody gave it to you, and nobody can take it back. The more you understand, the more you own your recovery.